Welcome to our webinar, The Clinical Impact of AI in Practice, a month in the life view of artificial intelligence for radiology practices, COVID, and beyond. With us today is Dr. Watanabe, Associate Professor, USC Keck School of Medicine, and Chief Medical Officer for CureMetrix. And with us today is Kevin Harris, President and Chief Operating Officer for CureMetrix. Delivering CAD that works, CureMetrix is a global leader in artificial intelligence for medical imaging, helping practices better predict and streamline their workflow while improving cancer survival rates worldwide. Let me now turn it over to Kevin Harris.
Thank you, Dawn, and thank you all for joining today. We're going to cover some interesting topics, I hope, sharing with you a little bit about where we think the state of artificial intelligence is, what's new for AI in radiology, and then a very specific case study for a month in the life of a practice that Dr. Watanabe will share with us. And then lastly, we'll talk about what you can do now during the COVID-19 crisis. So if you look at radiology today, in the United States, there's roughly 800 million radiology exams, 60 billion images, and that's a ton of data, a ton of studies. In fact, if you consider the number of radiologists in the United States, that's one study every 2 seconds for every radiologist. And there's never enough. When we talk to radiologists in practice, they are experiencing burnout, they are experiencing higher volumes, and with the exception of the time period we're in right now, the radiologists are trying to find ways to streamline their operations and be more efficient while not at all ever compromising the quality of their delivery. There's a lot of places where AI can add value throughout the clinical workflow, and I'm going to walk through a few examples right now. So first, if you explore where the patient and the radiologists interact, the first thing that typically happens is a technologist will come in and capture an image of the patient. So before the radiologist has even seen the image, AI can triage those images. AI can look at those images and evaluate which ones are suspicious, and working with the PACS system in the clinic can actually begin to route those images or group them to make them easier to read for the radiologist. This has a significant impact on the clinical workflow within the clinic. The next area where you can find some value from AI is where AI could read alongside the radiologist, acting almost as a virtual resident. It can help them to save time, to find things that they may have missed, and to provide confidence against overcalling or false positives. This is typically how a CAD has worked in the past, and probably what most of us think of when we think of AI, but the value that AI has goes even beyond this. AI could be in the role of a first read, a second read, or a QA. It can read the image before or after the radiologist, helping to either confirm findings that are found or highlight those cases that need to be looked at by a second radiologist. And lastly, in automated reporting. Today, there's a lot of dictation, a lot of typing, a lot of clicking. AI can actually help to auto-populate and pre-populate reports on both objective data, such as lesion size and lesion location, as well as interpretive data, such as breast density. Let's take mammography as a working example. In the United States today, there's roughly 40 million mammograms a year. And when you look at that globally, it's more than double that. Recruiting of breast imaging radiologists today is getting more and more challenging. And globally, the issue is even worse. When we go and talk to hospitals and radiology clinics around the world, what we often find is that mammograms are being read by OBGYN or primary care doctors, or worse, sometimes not at all. We're finding that there are significant backlogs in hospitals and clinics that can range from months to years for images that haven't even been read. Let's dig in a little bit deeper into mammography and breast cancer by the numbers. So as I said, there's about 40 million mammograms a year that happen in the United States. Now in a screening setting, if you think about it, for every 1,000 women who are screened for breast cancer, the doctors are going to recall about 100 cases. In the United States, it's about a 9.6% recall rate. For those 100 recalls, the doctors are going to find 5 cancers. That represents a 95% false recall rate. Now, for the 5 cancers they're going to find, there's 1 to 2 cancers that they're going to miss. In fact, when you talk to doctors, they'll tell you that if they find breast cancer on a mammogram this year, and they look at the priors going back to last year, somewhere between 20 and 30% of the time, they can see the lesion as actionable in the prior mammogram that they may have missed. That's a pretty high false negative rate when you consider the impact on the patient. And let's talk about that. Breast cancer is one of those diseases that when it's found early, and it can either be monitored or treated early, the survivability for the patient goes way up. And inversely, when it's found later and doesn't get treated until later, the survivability falls off a cliff. Now, AI can really help with this entire operation. On the one hand, you can think about AI being able to help reduce recalls and reducing unnecessary biopsies by not marking those lesions that are not suspicious, or by marking them but identifying them as very low suspicion. Alternatively, AI can also help to find those lesions which may be buried in a very dense breast, for example, and bringing those to the attention of the reading radiologist to help them reduce misses. So a transformation is happening in radiology today, and AI is really helping to drive that. It's helping to improve the performance of the doctors themselves. It's leveraging and amplifying this human experience. AI really learns like a doctor learns. It's helping to highlight pathologies and enhance efficiency, really driving a better quality diagnosis. It's putting more data at the fingertips of the doctors to help you improve the value of what you do and improve your diagnosis. And it's helping to reduce patient complaints, comorbidities. It's taking into account patient histories and genomics. And it's really taking us from where radiology has been for the last 50 years to where radiology is going to be for the next 50 years. So let's talk about a few things that are really new in radiology. The first thing that we're going to talk about today, and Dr. Watanabe will share more depth with you, is a product called CM Triage. And this is FDA cleared. And as you can see on your screen, what Triage really does is as a case is brought in, as a mammogram is captured, it goes to the cloud, it's processed by an AI algorithm, and what's brought back is an indication as to whether or not that case is suspicious or not. This allows, within the clinic, the doctors to be able to route and manage their workflow in a more optimized fashion. Those suspicious cases could be dealt with first. The less suspicious cases could be dealt with later. However the clinic wants to manage that indication, that's up to them. But AI provides that value, provides that indication directly to the doctor. In addition, while CAD has been on the market for 20 years, as we all know, it's never really met the expectations that were put on it. It's never really worked as people wanted it to work. AI is helping to change that paradigm. Through a product like CM Assist, AI can actually mark these anomalies and put a score next to them, helping for each lesion the doctor to understand how suspicious that lesion is. And this can work not just on current mammograms, but on prior mammograms. And the power of AI here is that it's not merely marking things just based on what it sees, but it is looking at the training set of over multiple millions of images to really understand what lesions really are suspicious and do need to be marked. With that, I'm going to turn it over to Dr. Watanabe, who's going to share with you a deeper story about how this actually works in practice, and hopefully you'll understand the power that AI has.
Thank you, Kevin. This research is an evaluation of the performance of the CureMetrics FDA-cleared triage platform for mammography called CM Triage. I will be presenting results of CM Triage in 2 different data sets. The first is a multi-institutional diverse data set which is enriched with a large number of cancers from 3 different facilities and mammograms which were obtained using multiple equipment vendors. The second data set is comprised of real-life series of mammograms, a so-called natural data set of a real-life batch of screening mammograms obtained over 3 months from a single academic center with no exclusions, or what we have nicknamed as a month in the life of a practice. CM Triage automatically sorts the suspicious mammograms to the top of the work list. Triage can be used to expedite recall of suspicious cases and for intelligent distribution of cases to multiple readers in a large practice. CM Triage can run at high sensitivity, up to 99%. In other words, cases can be sorted by the machine as normal or cancer-free with up to 99% accuracy level. The positive reader bias from the triage also enables up to 30% faster reading times and improved overall performance metrics for the facility. In the first test set, there were 855 confirmed normal mammograms as validated by 1-year follow-up and 400 biopsy-confirmed cancers. CM Triage correctly sorted almost all of the normal cases as low suspicion and correctly sorted 100% of the cancers as suspicious. There were no missed cancers. Therefore, suspicious cases can be expedited for callback and normal cases can be read later. Based on this data, there is potential for 58% overall workflow reduction if run in a standalone mode. Here's the breakdown of CM Triage performance based on this data set. The overall area under the curve of 0.95, where 1 is perfection, is shown to be consistent for calcifications, masses, different lesion sizes, and across all tissue densities, ranging from fatty to the more difficult, extremely dense breast. To further validate software performance, we performed a retrospective simulation study using a second data set of real-world data by taking a snapshot of an entire 3 months of screening mammograms from an academic breast center. The actual workflow results without triage are shown here, with a 13% callback rate and 15 cancers found, with a typical cancer detection rate of 7 per 1,000. In the simulation model with CM Triage, you can see that 62% of the normal mammograms were correctly sorted as low suspicion, which was more than half of all of the screening mammograms in this study. All the cancer cases were correctly sorted as suspicious, and in addition, there were 3 missed cancers, which were correctly sorted as suspicious, and the correct lesion was also flagged by the CureMetrics CAD. 55% of the false positive callbacks and 12% of the benign biopsied cases were all sorted as low suspicion and potentially could have been eliminated with the use of the software. So, how would this play out on an individual day? Well, on this real-life day, which was a somewhat slow day, there were 15 cases that were all read as normal without CM Triage. With the use of CM Triage, 73% of the normal cases were correctly sorted as low suspicion, plus there was an additional clinically missed cancer which was sorted as suspicious, and again, the cancerous lesion was correctly flagged by the CureMetrics CAD. On another day in practice, which was a little bit busier, there were 5 cases recalled, which were all false positives. With CM Triage, there would have been a 48% potential workflow reduction, and 3 of the 5 false recalls were also sorted as low suspicion by CureMetrics. And here is our last snapshot of an actual real-life day in this practice. There were 6 recalls, 2 of which had biopsies, and there was one cancer that was diagnosed. Using CM triage, almost half of the normal were sorted as low suspicion, and many of the false positive recalls were also sorted low suspicion. The recalled cancer was correctly categorized as suspicious, and again, an additional clinically missed cancer was identified by the CureMetrics AI, which was confirmed at a subsequent biopsy. So, in summary, in this real-life scenario, there was potential for dramatic recall reduction as well as biopsy reduction. Over half of the screening cases were correctly sorted as low suspicion with no missed cancers. In addition, there were several clinically missed cancers with potential to increase cancer detection rate in this practice by 17% or an additional 1 cancer per 1,000. So, how does CM Triage stack up with the published literature? The AUC of the software with both of these test sets is shown here to far surpass previously published models, with neither of these other models achieving the 99% sensitivity level, and there were missed cancers in what was classified as very low suspicion or cancer-free in these other models. CM Triage has hit the mark in identifying normal mammograms with a high level of accuracy, which is at and above average human performance levels. We identified 3 actionable missed cancer lesions in this month in the life study, which were validated by 2 independent mammographers. All of these missed cancers were flagged by CureMetrics up to 14 months prior to the actual clinical recall. In this published reader study of missed cancers, CureMetrics CAD as a standalone outperformed all the readers. But more importantly, the readers all showed significant improvement in performance with the use of CureMetrics CAD, with an average of 27% increase in cancer detection rate and no significant change in the overall recall rate. Here's an example from the study of a missed cancer that had a high new score, which was flagged by CM Assist and marked suspicious by CM Triage. This cancer grew and was eventually recalled from screening 14 months later. And here's another example from our Month in the Life study. A small group of pleomorphic calcifications with a high new score that was clinically classified as benign and eventually had a recall at subsequent screening with a positive biopsy. With the unexpected changes in healthcare due to COVID-19, it's projected that over 3 million mammograms are canceled every month in the U.S. alone at this time. However, we know that a surge of patients will soon return for their screenings, and it will be more important than ever that we take measures to handle the rebound. This is the best time to implement AI in your practice. Make the most of your downtime so technical staff and radiologists can familiarize on how to use CureMetrics AI. This cloud-based software integration can happen quickly and remotely. To support radiology practices during our healthcare crisis, CureMetrics is offering no-cost implementation and no cost for service for the next 3 months. Our goal is to arm radiologists so you can serve your patients and put your practice back on track. In summary, the radiologist using AI will outperform the radiologist who's not. Benefits include faster reading time and improved turnaround time, false negative reduction, improved cancer detection, and earlier cancer detection. We're all in this together, and CureMetrics is ready to help with FDA-cleared workflow tools to reduce your stress, recover your practice, and manage your backlog. CureMetrics AI benefits the radiologist and the facility with the end result of better patient outcomes.
Thank you to our presenters for sharing their expertise And thank you to Aunt Minnie for helping us bring you the clinical impact of AI in practice, a month in the life view of artificial intelligence for radiology practices. I trust you will find the information today can be applied in your practices right now to support you during the COVID crisis and beyond. You can read our published studies at curemetrics.com or access them right here in the Aunt Minnie virtual conference portal. You can also request a demo of our AI solutions at info@curemetrics.com. Thank you.